Welcome to Infectious Disease Grand Rounds. There is no commercial support for today's program. The speaker and planners have disclosed no relevant financial relationships with commercial interests. If you have a question for the presenter, please hold until the Q&A segment at the end of the talk. If you're attending virtually, you can add your question in the Q&A section and we'll read it aloud for you. A link to the event survey will be shared at the end of the program. And now it is my pleasure to invite Dr. Supriya Manipali, our Director of Infection Prevention and Control at NGMC, to introduce our speakers.
No, thank you. Thank you. Thank you everyone for attending the Grand Rounds today. It is my pleasure to introduce our guest speakers from Department of Public Health, District 2, Chen, Nicky Winniford, and Dani Rigal. We're very thankful for their collaboration on several infection prevention and control initiatives. And Chen graduated with a Master of Public Health from University of Georgia in 2023, and she began working at the District 2 Office of the Georgia Department of Public Health as an epidemiologist shortly afterwards. In addition to case and outbreak investigations and follow-ups, they also conduct data analysis, visualization to review trends in notifiable diseases and community health status. Such information is shared with stakeholders such as NGHS, and they're delighted to be here to share the STI statistics with us today. Nicky Winniford holds a degree in education from Branagh University and a degree in public health from University of Georgia. She began her career with the American Cancer Society, where she focused on early detection education and facilitated support programs for cancer patients. After spending 18 years educating young children, Nicky returned to public health in 2022, and she currently serves as the outreach coordinator for the family planning program, providing services across 13 counties in the region. Nicky is passionate about ensuring access to care for all women. She resides in Houston with her husband, Brian, and their 2 teenage daughters. And last but not least, we welcome Dani Rigal. She serves as the HIV prevention and PrEP coordinator at District 2 Public Health, where she leads efforts to expand PrEP awareness, HIV testing, and linkage to care across 13 counties in Northeast Georgia. She's also co-chair of the HIV Prevention Community Advisory Board, partnering with community members and healthcare providers to strengthen prevention strategies. With 4 years of experience in HIV and PrEP services, Dani has contributed to the program growth through outreach, community partnership, and innovative approaches to making services more accessible. She holds a Master of Public Health in Epidemiology from East Tennessee State University, where her graduate research focused on the lack of PrEP uptake in the southern United States, particularly among African American and Hispanic men. Her work emphasizes equity, inclusion, and meeting people where they are in their healthcare journey. Please join me in welcoming Dani, who will be our first speaker now.
Good afternoon, everyone. I'm Dani. I am the HIV Prevention and Linkage Coordinator for District 2. If you are new to this area here, our district is actually composed of 13 counties. They reside in the northeast region of Georgia. We border North Carolina and South Carolina. And it's very much a district that is very diverse. We have places like Gainesville, which is very similar to some of Metro. And then we have rural counties, far out where do not resemble anything of Atlanta. I want to disclose that we have no financial relationships to disclose. My presentation is titled, Seeing Women Clearly, Breaking Assumptions in HIV Care. So today we're going to explore how preconceived notions in healthcare can hurt women, especially when it comes to HIV testing, prevention, and treatment. We often think of HIV as something that primarily affects men. But women, such as our mothers, daughters, partners, professionals, people we interact with on a daily basis, are often left out of the conversation. And that silence can be dangerous. To understand what this really looks like, I want to tell you a story about Maria. Now, Maria, she's a working mom, juggling job, kids, husband, everything in between. For months, she's been struggling with unexplained fatigue, infections that won't clear up, and weight loss she can't explain. Now, Maria goes to her doctor, right? The doctor gets blood work, screenings, routine checkups. However, there's one test that's not done and it's not offered to her, HIV. And you're probably asking yourself why. In most practices, it's because she doesn't look like someone that could have HIV, because she doesn't fit the assumption of risk. Months later, Maria lands in the ER. Her symptoms have worsened, right? There, she finally gets tested and learns that she has HIV at a late stage. Now imagine if her doctor had offered this test in her first visit, or she had been told about PrEP years earlier. That small shift could have completely changed her story. And Maria isn't alone, right? This happens to women across the country, women who interact with healthcare systems on a regular basis but are invisible when it comes to HIV prevention and testing. That invisibility comes from one thing: assumptions. The problem with preconceived notions, right? Healthcare providers may unintentionally overlook women when accessing HIV risks. The result is going to be mistesting, misprevention, delayed care. Now, I want to expand on this because I feel like sometimes providers may feel attacked. I'm not saying that providers are malicious, but they do carry assumptions. And one of the strongest assumptions in women is that they are low risk. I have been in the field where I encounter providers on a daily basis and try to educate them or help them be able to offer these services and have these conversations with their patients. I actually had a provider tell me once, "I just don't think of HIV when I see women in my clinic." And that mindset adds to this preconceived notion, right? So I want you to be really honest with yourself right now and think, when you hear HIV, who comes to mind first? Was it a woman? I mean, and the same goes for me, right? When I think about HIV, most of the time I think about males who have sex with males, transgender women. Those are probably my top group of people. What does this data look like, HIV among women, right? We know that in 2023, women made up nearly 1 in 5 new HIV diagnoses. Half of those were Black women. Black women's rate of HIV is almost 10 times that of white women. These stats are very alarming, especially for Black women, right? They remain at high risk, and we haven't yet designed a system that can keep up with the pace of their needs. However, these are not just numbers. They are, like I mentioned earlier, our mothers, students, professionals, women who deserve prevention and testing earlier. This is actually supposed to be a video, but it's not gonna play because your website does not allow for YouTube videos to play. So I'm gonna tell you her story. This is Teresa. Teresa was recently divorced. This happened 16 years ago. She went on a date. Her friend recommended this gentleman, blind date. Months later, this gentleman was given the diagnosis of HIV, and he contacts Teresa so she can get tested. The first 30 days, she was testing negative, and then after that, she tested positive. She goes on to explain that she never thought she would be a person who would have HIV. Didn't think about testing regularly or the prevention that comes with testing often or the resources available to her. She also talks about how scared she was when she received that diagnosis. And next to her is her daughter, who talks about the importance of being there with someone who has been recently given that diagnosis, right? Building that support group for them. When we look at the numbers, right, we think about, all right, 1 in 5 are women, and half of those are Black women. But I also think it's important to share stories like Teresa, because those stats can just seem like an abstract at times. And unfortunately, Teresa's story is not unique, right? Her experience highlights how women are often left out of HIV prevention and testing conversations until it's too late. And that raises the critical question, why are women being overlooked in the first place? So let's take a closer look. The first one is gender assumptions about HIV risk. Even experienced providers may unconsciously assume women are low risk. And if you compound that with lack of provider training, then you have social stigma, and that is leaving women under-tested and under-informed. Bias isn't always obvious, right? Sometimes it's subtle, and sometimes it's shocking. I'm gonna share with you an example of that. Not long ago, I had a provider who had admitted a patient, a female patient, with pneumonia, and he ran a full panel of all the different tests to try to figure out what was causing all of this. He did HIV, and the test came back positive. Now, the reason he was speaking with me is because he didn't believe that she had HIV. So I suggested he run a viral test to see what the viral load would be. Her viral load came back, she was AIDS. He didn't think she was HIV, even though the lab was telling him she was HIV positive, because she didn't look like that risk that we like to assume of, right? And the outcome of that was delayed care. Not that he wanted to delay her care, but unfortunately, that's the aftermath when we have those assumptions. That is what gender bias can look like in healthcare. Women diagnoses are questioned, their symptoms explained away, the risk underestimated, even in the face of hard evidence like an HIV test telling you the person is positive. And that can cost their lives. I know that PrEP is not something that we talk about. So let me ask you here, if you are a woman, right? How many have ever had a provider bring up PrEP to you personally when you went to go see a provider? I know mine hasn't. Oh, yours has, that's great. I know mine hasn't, but my provider is an amazing doctor. She knows what I do for a living, so that's probably why she's not talking to me about PrEP. But when I talk to my colleagues, I've asked them, and none of them have had that conversation. They are aware of what PrEP is, but they have never had that conversation. Now, we know PrEP is highly effective, and yet women are largely missing out on what PrEP can do for them. So we need to normalize PrEP education, make it accessible for every woman who could benefit. And just to give you an idea, 1 in 10 women who could benefit from PrEP are not being prescribed it. Georgia alone, the PrEP-to-need ratio is 2 for women and 7 for men. That gap is not about science. It's about access and awareness. And I want to expand on that because when we think about awareness and access especially, we think about, well, maybe there's not a clinic nearby. Who would be the pharmaceutical company that would fill this prescription? Would they have access to what this would cost and stuff of that sort? But that can also look like if you as a provider are not having conversations with your patients about their options, then you are actually removing access from that patient. So let's talk about reframing this risk, right? My top one is my favorite. Risk does not equal assumptions about behavior. So instead of asking, does she fit a risk profile? Providers should look at a broader context. Geographic prevalence, community incidence, patient education matters more than stereotypes. We need to stop asking, does she look at risk? And instead ask, what is the prevalence where she lives? What is the incidence in her community? Risk is not an individual stereotype. It's an epidemiological reality. And I personally believe that every woman deserves education and testing. What needs to change? Honestly, we need to shift our approach. We can make sure that women receive timely care, prevention, education, life-saving interventions. We need to normalize HIV testing in women's healthcare visits. I know that in OB we do that, but not just OB, right? Family planning, urgent care settings, whether she's going for a UTI or whether she's going for something else, maybe that's the time to have the conversations. I know that sometimes providers can at times get comfortable if, for example, the patient has access to my chart. And I know because I have access to my chart, and there is a notification that says HIV, exam needs to be done or is overdue. But if I didn't know my risk, I probably will ignore that. So we need to normalize PrEP conversations the same way we talk about birth control, vaccines, or pap smears. So I want you to think, right, what would it look like if HIV prevention was simply part of routine women's healthcare? No stigma, no hesitation, just making it routine of their actual healthcare. It probably will empower them to be able to make decisions about their health. So let's return to Maria. She finally learns her diagnosis. Her first thought wasn't about herself, it was, who will be there to take care of my kids and my family if I can't? That's a fear that no woman should carry because a test wasn't offered. Maria's story is not just one story, or Teresa's for that matter. It's a reflection of a system that too often overlooks women when it comes to HIV. She did what she was supposed to do. She went to the doctor, she followed up, she trusted the system, and still prevention and testing were never brought up until her symptoms have worsened, right? Now, I do believe this does not have to continue. If we test all women, if we normalize PrEP education and testing, if we see women clearly in HIV care, then Maria's story becomes the exception, not the rule. So like I mentioned, we talked about Maria and Teresa and the thousands of women behind the stats. I think the message is very simple and urgent. Every woman deserves to be seen. Every woman deserves to be offered an HIV test. And every woman deserves to know about PrEP. If we can shift our assumptions from action, if we can treat prevention as part of routine women's healthcare, then the next Maria won't be missed, and then the next Teresa won't have to tell the story of being overlooked. So before I take questions, I did put this slide here because I wanted to kind of share with you guys some of the common questions that I get from providers when we're interacting with them about PrEP, right? Are men the main group affected by HIV? Why focus on women? It's true, men make up the majority of new HIV cases, but we learned today that as of the latest data from the CDC in 2023, 1 in 5 is a woman, right? Especially Black and Latino women. They face higher rates of late diagnosis, less awareness of PrEP, and fewer prevention options offered. So this makes them a critically important group for education. Is PrEP effective for women? This question mostly comes from my OB providers, and I can understand. But yes, PrEP is highly effective in women when taken correctly. It reduces the risk of acquiring HIV through heterosexual contact by more than 90%. The problem here is not effectiveness, but access and awareness, right? Just too many women simply don't know about PrEP. How do we talk about HIV prevention with women without making them feel judged or stigmatized? I think that is most common with my nurses, since they're seeing women on a regular basis at healthcare departments. Honestly, the answer to that is just by normalizing the conversation, right? The way you're talking about other prevention in their health, just bring up PrEP as well. And it's not so much of just checking off a question, have you used PrEP, or do you know what PrEP is, have you seen a commercial, but actually explaining what it can do for them. Why don't more providers bring up HIV testing with women? In my rural counties, many providers still see HIV as something that primarily affects men who have sex with men. That bias influences their clinical decisions, right? So by reinforcing this provider training and making sure that they understand that women also have a risk and it could be deadly to them if they don't have options, then we can actually change that. And it goes to my last one, what's the first step we can take to close this gap for women? And that would be offering them their options and educating them. If you empower your patients can then make those decisions about what's best for them. And not just with the resources, but also maybe educate them of what the prevalence is in their community so they get a bigger picture of that. Thank you for your time and support. I think that together, if we actually make this happen, we can create a healthier Northeast Georgia.
Okay. Does anybody, Dani, do you want to take any questions now?
Sorry, I forgot about that.
Does anybody have a question for Dani? Up front? Where do we see? Raise your hand. Okay.
Thank you, and that was really good. So what about insurance companies? How do they cover this? And if they don't have insurance, what happens?
Right, so there is several programs. For example, for insurance, most of them that do cover it, we work with our team for prior authorizations. Those insurance that do not cover it, there is programs through different patient access, like different pharmaceuticals that have, like Gilead has patient access. And so we're able to still get them that type of care, either at no cost or very, very low cost. So we do work with those patients who may have those challenges.
Thank you so much. We have another question over here.
Why do you think it is so difficult for?
So everyone can hear you.
Why do you think it's so difficult for physicians to talk about sexual health to their patient? Is it due to biases or their lack of, or their upbringing that they feel uncomfortable? And I mean, for those
Right,
reasons.
so this is more on an observation basis to kind of answer that, right? I think it has to do with the culture depending on the area we're talking about, where maybe if you've been to a practice in, let's say, Fulton County, right? One, they're very aware of what that prevalence is looking like for not just HIV, but other STIs as well. So maybe those conversations are happening more often, where maybe in a smaller town like Blairsville, where you kind of know everybody there, you kind of all grew up together. Maybe they even know the provider, so they're not bringing up any of their symptoms. Maybe the provider doesn't want to bring up the conversation, so the culture there is very different. And honestly, this one, and I take this one personal, I think it's because of how we advertise it. I understand that the priority risk is still men who have sex with men, but even our commercials, there's no representation for females like that. So when I'm watching, let's say, my morning YouTube podcast, and a Hulu commercial comes on for some pharmaceutical talking about PrEP, all I see is either transgender women or gay men. So there's no one that represents me, right? If I was a single female, I'd probably be like, oh, this is not for me.
And we'll take a question back here.
Yeah, thank you for your presentation. I had a couple of questions. One about PrEP. Again, as you said, what comes to mind is like the straightforward high-risk population, but the example you gave of just like your average Joe lady, like should I be testing people for HIV more than once in their lifetime, even if they're not high risk? That's one. Two, PrEP, is it just suggested to everyone, bring it up to everyone?
So I'm going to answer your first one, and this is a question that I get when I'm doing outreach non-clinical testing, especially for my age group between 19 to 25. This is what I tell that college age group. You should at least be testing every 90 days. And if you have multiple partners, that way they don't have to like engage with me because I can understand you just met me. You're not going to sit here and tell me all about your sexual life. Then test every 30 days. And so that should be recommended, right? Because it does happen. Sometimes patients do not disclose what their sexual behavior may actually look like. And then the other question, should we be testing everybody? Or should we be offering PrEP to everybody? I think so. We have patients who are, in their 50s, 60s, 70s, who are on PrEP.
Thank you so much. For the sake of time, we're going to move on to our next presentation. If you do have more questions for Dani, we can ask more questions at the end of the presentation. Thank you. Thanks, Dani.
Hello, everyone. I'm Kai, and speaking of STIs, we're now going to discuss the burden of STIs in select northeastern Georgia counties for the past 5 years that we have data on. Spoiler alert, the northeastern Georgia counties that we're going to be talking about are for District 2. So a little bit of background first. So nationally, millions of STIs infections occur in a year. So as of 2023, Georgia ranks 5 for chlamydia, 3 for gonorrhea, 14th for primary and secondary syphilis, and 18th for congenital syphilis. So Georgia really isn't doing too great. Now, let's shift to a narrower range of land. So District 2, we're the North Health District. We cover the 13 counties of northeastern Georgia, and most of our counties are actually also covered by NGHS, the Northeast Georgia Health System. So Hall County hosts Northeast Georgia Medical Center Gainesville and Northeast Georgia Medical Center Brazelton. We also have an NGMC in Lumpkin and Habersham. So outside of hospitals, NGPG clinics are all over our district. We have them in Forsyth, Dawson, Stevens, Rabun, Franklin, Hart, and White. And although it says rural counties right there, Forsyth is not a rural county, but just to show how our spread is. So let's get into the data. For the past 5 years, chlamydia, gonorrhea, and syphilis rates have increased a lot. And so you see this most substantially with chlamydia. We see that clear, steady trend upwards into 2023. As for gonorrhea and syphilis, the rates are lower. However, that does not mean the rates aren't increasing. And so let me see if I can zoom in here. Sorry, this mouse is not doing too good. So just these, right? We see increase still in gonorrhea, and comparing rates for 2019 and 2023, syphilis has doubled, over doubled actually. For congenital syphilis, we actually see a decreasing trend from 2019 to 2022, and then a spike in 2023. We're still waiting to see if 2024 data shows that increasing trend, or if the spike is only relegated to 2023. If we only look at 2019 and 2023, we'll see percent increases for all of them. 6.2% for chlamydia, 17.6% for gonorrhea, and as I mentioned, over doubling of the syphilis rate. And then for 2019 and 2023, 25% increase for congenital syphilis, but we still did have that decrease. Now, let's see. This is a comparison of all the counties hosting NGMC hospitals. So here we see Hall County in dark green. Barrow County is added for context because the Brazelton Hospital also covers Barrow County. Then we have Habersham and Lumpkin. So right away we can see that chlamydia has a very high rate in Hall County. It is very high compared to where it was in the previous years. And then we're also going to take a quick look at Habersham for syphilis. So what you'll actually realize is that you'll have to think about rates a little bit carefully in this case. Habersham County hosts Lee Arundel State Prison, so that accepts transfers from all across the state of Georgia. And so what we see for the rate of syphilis in Habersham may not be the true representation of what syphilis will be like for the general Habersham population. Now, rotating back to congenital syphilis. So in general, we see that there are very few cases in a single year for any county. The maximum number of cases we've had in a year just for the 4 counties previously mentioned was 2. However, the case counts here really do help to paint a clearer picture of how many untested pre- or perinatal cases might be identified in a single year. And it might just be that they were untreated, they did not receive pre- or perinatal care due to concerns about insurance, but it helps indicate how many cases we're going to miss. So again, just as a summary, both chlamydia and syphilis rates have been increasing since 2019 pretty steadily. We also see this with gonorrhea, though not as much of a, not as similar, not as rapidly or consistently like the other two. So we already talked about congenital syphilis. What about the average patient then that you will see in your clinics, in your hospitals? So first, let's discuss gender. One contributing factor as to why we see a lot more female cases of chlamydia than male cases is actually because men tend to experience fewer symptoms, and so they seek STI care less. So the male cases and rates that we see are actually going to be underreported because if they don't have symptoms, they're not going to come in and they're not going to get treated. However, it is very important that we still reach out and make sure that they do receive treatment because that is an infection, and if they're not notified, they're going to spread it to others. And then we talk about gonorrhea and syphilis. So actually, in Georgia, our frequency of male and female cases seen is different to what we see in the district. So in the district, we actually see a higher frequency of female gonorrhea and syphilis cases than for Georgia as a whole. And so it's really important to consider that in context. What is applicable to one area may not necessarily be the same for a more specific area when you go practice in your clinics. Now, race and ethnicity. So most STI patients that we see in our area are white non-Hispanic. However, the rates for Black non-Hispanic and the Hispanic populations are much higher. And so we see that the STI rate for the Hispanic population is double that of the white non-Hispanic population. And then the Black non-Hispanic population has a rate that is a little less than 3 times that of the Hispanic population. So let's talk about possible barriers to care next. There are several major reasons why someone may not get tested or might not seek treatment. So first is transportation issues, cost, and then concerns around stigma and confidentiality. So let's expand on those. First up, we have transportation. So after COVID, a lot of rural clinics and hospitals had to close. And currently, as of 2024, up to 60% of rural critical access hospitals in Georgia are at risk of closure. I believe actually St. Mary's Sacred Heart in Livonia recently had their delivery unit close, so patients will have to travel further to get care. And then let's take this into context a little more. So a Hart County resident who has suspected neurosyphilis, they would have to travel 50 to 60 miles to the nearest hospital for testing and treatment. And so 50 miles is about the distance from Gainesville to the Atlanta airport. And so who wants to travel that long just to seek care? It's an hour there and an hour back. That's a lot of time lost for the average person. All right, cost next. So 10 out of our 11 rural counties have a population of 10% or more of their people in poverty. And so I believe actually in the most northeastern of our counties, that percentage is 13 to 15%. So for providers practicing out there, it's very important to keep this in mind. For those without insurance, STI treatment, STI testing can be very expensive. So here's a list of commonly used antibiotics for STI care and their costs without insurance. We have azithromycin, ceftriaxone, doxycycline. Okay, $25 to $30, but then you get to bicillin. Bicillin is the only antibiotic that is currently used to treat patients who are pregnant with syphilis. And so most clinics actually won't carry this antibiotic. They will have to send them to the health department for treatment in this case. Bicillin, I don't know if you can read the footnote. I don't know if it's big enough. Bicillin is also currently in shortage. So currently, health departments are prioritizing Bicillin for our pregnant patients who have syphilis. Next up, we have the next barrier to care that we have, is stigma and confidentiality. Now, Dani had previously touched a little on this. Rural counties experience something unique called overlapping relationships. So this means that their provider could be a friend, a relative, a neighbor. And so because the circle of people the patient knows is so small, there is to them, the risk of confidentiality is incredibly important to think about. They may not talk about their symptoms because they don't want information spreading. They're scared of that. They don't want to be identified. And then if they don't want to be identified, if they don't want to talk about their symptoms, okay, that also creates a barrier to partner notification. Their partner isn't going to know necessarily that they need to have testing and treatment as well. Now, let's talk about one more factor that wasn't mentioned actually in the previous slide. So that is cultural context and other factors. So 56% of District 2's Hispanic population is found in Hall. 38% of the Black African American non-Hispanic population comes from Hall County too. So in many Hispanic cultures, discussion of sex and STIs remains taboo. They're not going to want to really talk about it because in their culture, it's pretty embedded. Next, historical distrust of the healthcare system might dissuade Black non-Hispanic individuals from reaching out if they have symptoms. We also have religion. They may not want to seek STI care due to religious factors. And then one other thing that I didn't put on this slide is actually Georgia's sex education. We don't really have a good handle on making sure that people know the risks very well. And so the most important part in all of this is to remain approachable to patients, no matter their beliefs or background, what they look like, or where they come from. So here are some of our concluding thoughts for this presentation. When there are very few clinics or hospitals in rural areas, oftentimes the first place they go to seek STI care is actually the local health department. And so the health departments, all health departments in District 2 operate on a sliding scale. So our services remain affordable to patients no matter what. But we also rely on you, our local healthcare system, to make sure that everyone gets testing and treatment. We coordinate together on notifiable disease reporting and follow-up. We also make sure, again, that every patient gets testing and treatment, and we will work together to ensure that. And so, thank you. No matter what, we make sure that patients always get the care and help that they need. This is a community survey on STIs that we're promoting. So you can take out your phones and take our survey really quick. It's essentially, we want to look at what current community attitudes towards STIs are, and then also how much of the factors we previously mentioned, cost, transportation, stigma, and confidentiality, how much of those factors is there one that patients worry about the most? And so if you would also distribute this survey to your patients in their future clinic visits, we would really appreciate that. this survey will remain up for a while, and we'll make sure that people who attend will also receive this in their emails. So, thank you. Any questions? Or did I go too long?
No, you did great. If you have a question, please raise your hand. I'll bring the microphone to you. Sure you can.
Thank you. This is a general question, I think, for you, Kai, and as well for Dani. So for the folks in the room, obviously, I imagine we have some acute care providers, some outpatient providers, things like that. Is there anything in place with District 2 and the Health Department if any of these folks are looking for either further education, potential patient referral, maybe they want to learn more about PrEP, learn more about having sexual health conversations? Is that something that the Health Department can help them with? And how?
Thank you. So I will say that we do education and outreach activities. I'm not as linked to the clinic part of our health department as Dani is, I believe. So if Dani also wants to chime in at any point, please feel free.
This is so everybody online can hear you as well.
Right, so when it comes to, and I do want to make that note here, so our epidemiology department mostly focus on other STDs, and I focus on HIV. So when it comes to HIV and PrEP, we do offer something called, we designed it, is a provider PrEP kit, where it basically tells you what kind of labs need to be run, how often, what medications are available, what symptoms the patient can experience. And then we have also available a PrEP navigator that a patient can call if they are having the symptoms or if they're having other issues so that we can connect them to the correct resources. So we do provide those educations.
Thank you so much. And in the essence of time, we'll go ahead and have Nicky present. But do you have a comment first?
Some of the stuff I'll be presenting will actually kind of go into that as well. Good afternoon. I'm Nikki, and to just piggyback on your question there, I'm going to be talking about the Women's Health Services and family planning services as well at the health departments. So one of the things that we do is women health exams. And on those exams, our providers take as much time as the women need for any questions that they may have and educating on the different birth control methods as well as other conditions that they may have. So one of the things with the health department is they take the time, they have the ability to take as much time as possible. So answering any of the questions that they may have or any concerns, especially nowadays in social media, there's different myths that go around related to women's health issues, especially when it comes to birth control. So some things are just, once something gets started, it kind of becomes a myth that people think is a true situation. So with our on-site birth control, we have all the methods available on-site. So if a woman sets up the appointment, she can get everything taken care of at one appointment. This also helps with transportation. So instead of coming in for a visit and having to come back, a lot of times that can be planned in a way that it can be all done in one trip. And of course, all our appointments are confidential. This goes into too if there's a young woman under the age 18 that may want to keep it confidential for various reasons from her family. She's able to come in and get care. And again, that's confidential. Once you're of reproductive age, you are in control as far as birth control and other services that way of their own health care on that. We also provide the STI screening and treatment, so all the different methods that way, and being able to promote PrEP and giving them over to Dani and those to be able to provide those services. Another resource we have is for women in need of feminine hygiene products. Period poverty is a real thing, and especially now as all the expenses become more and more, we do have that services as well as we have condoms free at all our health departments as well. To kind of go in, all our 13 counties have their own health departments. So I have listed along the side all those different health departments that they're able to go to. And a lot of times if they don't want to go within their community, they could go to a neighboring county to kind of address some of the issues that Kai had spoke about. One of the really great things that we've done is made a QR code. So on this, they can do the QR code, request the appointment, and somebody from the health department that they choose will get back with them. As well as we have a navigator, Xiomara, who is available for questions. And she is Spanish speaking, and she also kind of brings, you know, the concerns down, many of which that Kai had spoke of as well, with kind of that cultural and comfort and coming in from, you know, birth control to just even different women's health exams. So we do have a person that they can call and ask those questions, or maybe help navigating the process there of getting an appointment. All our family planning is done on a sliding scale, as well as if you're 18 and younger, they can go all the way to 0, and there'll be no cost for those teens because that protection is very important for that age group. And then another really great program that we have is a no-cost mammogram program. This program provides mammograms, but what's really great about that is in addition to covering that screening mammogram, if additional diagnostic testing or is needed, it covers that as well. And if cancer were to be found, we work with hospital charity as well as a women's health Medicaid program that can get the treatment that they need. Because we know early detection saves life, and at the same time we understand those different barriers. One of the barriers, again, is transportation. So with this program, they're able to do the different intake process online, and then we typically use a Northeast Georgia Imaging Center, and we help the lady get the appointment set up. There's a nurse that follows along with the program, so if additional testing is needed, they'll help them get those set up as well, and those covered. So the women that are able to be a part of this program are age 40 to 64, typically at 65, Medicare will take over the expenses. However, if the woman over 64 is not enrolled in Medicare Part B, then she would be eligible. And this, again, if they're uninsured or underinsured. What is underinsured? That means basically they cannot afford the deductibles that may be involved. And there are some insurances out there that are like major medical, and they don't cover the preventative care such as mammograms. There is an income requirement, but it's 200% of poverty, which most working families, so it would be a family of 4, around 62,000. Most working people do fall within that 200% of poverty. And again, as Kai mentioned, many of our counties are at 13 or, you know, over 10% poverty rate. So of course, all of those patients would definitely cover. One of the things that we do see is that women of color a lot of time don't seek early detection as often, and therefore that puts their mortality rate higher than women who are getting early detection, so that they can kind of get in there. If things are caught at the very beginning, it may just be removing the tumor and not having to go in through the more radiation and chemotherapy when we find that early. So it's very important. Again, we have a QR code where the women can fill out and what health department. Now, this QR code just goes within our region. However, this program is available throughout the state of Georgia. Each district may manage it different. So if you know somebody in Georgia that would fall into this, have them contact their local health department and ask about how their district works the program. Some are slightly different, have different process. So on ours, do the QR code. It used to be that they always had to come into the health department for a clinical breast exam, but what I was saying now is that they can do everything online and not have to come in if that's a barrier. As always, we would love for them to come in and do a complete health exam and have that clinical breast exam as well. However, it is not required. So that kind of covers that program as well. Do I have any questions from either program or?
If anybody has a question, please feel free to raise your hand. I'll bring the microphone over to you. Any questions? We have one over here.
All three of you did a great job. I'm Dr. Krukey. I'm from Houston, where I took care of HIV/AIDS patients since the 80s. I'll be giving a lecture next week on PrEP to the graduate medical education group, to the interns and residents. And if you can come, we'll be talking about PrEP and sex and all those kind of things that are important. You all did a great job.
Thank you.
Thank you very much. Thank you. Before I hand it off to Dr. Manapali to close, I'd like to remind you there are program flyers on the registration desk about the programs that were discussed today. And also, if you did not scan in to check in today, please make sure you do that before you leave so you can get credit for attending. And here's Dr. Manapali.
I just see a lot of our DVH partners here today, so just want to thank them for all the great work they do in our community, and especially thank you, Dani, Kai, and Nikki for the great presentation today, educating us. Thank you.